Assalamu alaikum, everyone. I just want to welcome everyone to another session of Dent Talks webinars by MBRU. My name is Mohammed Jamal, Assistant Professor in Endodontics. And today it is our privilege to welcome one of our mentors, Professor Stephen Morgano, who is a professor and chairman at the Department of Restorative Dentistry and the director of the Advanced Specialty Education Program and Prosthodontics at Rutgers School of Dental Medicine. Dr. Stephen Morgano, he did graduate from Tufts Dental School, and he did complete his GBR program at the Philadelphia General Hospital. And then he is now the professor and chairman of the Department of Restorative Dentistry and the director of the postgraduate specialty program in prosthodontics. And he is a diplomate of the American Board of Prosthodontics. Dr. Morgano has published over 75 journal articles and more than 14 textbooks chapters, and he did lecture throughout the United States and 16 different countries. I just want to welcome Dr. Morgano, and I want to thank him for participating in Dent Talks.
Thank you, Dr. Jamal, for your introduction. This presentation, I gave this presentation last fall of 2019, at the American College of Prosthodontists board preparation course for the American Board of Prosthodontics. And I have no conflict of interest in anything with this presentation. So we're going to talk about complete mouth rehabilitation with fixed prosthodontics. So if we look at our diagnosis and treatment planning, it's like playing a game of chess. In order to play the game, I have to know how to move the pieces. And I do know how to move the pieces for chess, but I'm not a very good chess player. There's other things we need to do. We need extreme attention to detail. We have to watch the whole board at all times. So when I'm playing a game of chess, if I lose my queen, I'm going to lose the game. And with complete mouth rehabilitation, we have to pay extreme attention to detail, especially the occlusion. If I manage to do a malocclusion, I'm going to end up with a failure. And then, of course, experience helps. You know, my 100th chess game, I'll be better than my first chess game. So we're going to describe step by step how we do a complete mouth rehabilitation. So again, occlusion is extremely important, but it's linked. Occlusion is linked to aesthetics and phonetics. So if we look at this artwork here to the right, the incisal edge of the maxillary central incisors, when the patient makes the F sound, it should brush the lower lip at or near the wet dry line. When the patient says S sounds, the incisal edges should come very close together, usually 1 millimeter to 1.5 millimeters apart. So we're going to show you a case where the anterior guidance was dysfunctional and show you what we did to correct it. So our contemporary approach to occlusion is biomechanical. Okay, the biology comes from the muscles and the periodontal ligaments, but we still cannot ignore the mechanical component. So we're going to discuss biomechanical principles of occlusion, and then we're going to talk about how do we create an artificial occlusion with the information that we have from studies that have been done by some of the pioneers on occlusion. So if we look at the pioneers on occlusion, okay, Purcell published a book in 1968, based upon all of the research he had done on jaw movement. But he essentially evaluated the envelope of motion, or the border envelope. It was Lundin and Gibbs who published a book also called Advances in Occlusion that again summarized research that they had been conducting, but it was not the envelope of motion. It was the envelope of function, which is really what we're interested in. All right, so if we look at this artwork here, this is not mine. This is from the actual Gibbs and Lundin's textbook. So if we ask the patient, please close. Now just imagine there's a black dot right between the two mandibular incisors. We ask the patient, please close, and the patient closes. And this is the maximal intercuspal position, or MIP. Then we ask the patient, okay, please slide your jaw to the left as far out as you can go. So the black dot would move all the way out here. Then we ask the patient, okay, now please open as wide as you can open. And the patient would open, gradually going back to the midline, and that's the maximal opening. Then we ask the patient again, close until all your teeth fit together best. Okay, that's MIP. And then slide all the way to the right, and then open, open, open until you can't open anymore. So this diagram here, this is Posselt's diagram. So that's the border envelope, or the envelope of motion. So what Gibbs and Lundin did, they had a computer called a gnathic replicator, and they could monitor how the patient chewed. And that was what they called the envelope of function. So again, imagine there's a black dot right between the two mandibular central incisors, and they gave the patient food to chew. And what they found was that the patient would open relatively straight. The patient would move towards the side with the food, which we call the working side, and then the jaw would come up, 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 up until maximal intercuspal position. Now they also found with very hard foods, they didn't get through the food with the first few chews. Soft foods, they got through the food. But they also found something extremely interesting. When the patient came up, the canines would just barely miss if the patient's anterior arrangement prevented posterior contact of any of the posterior teeth during eccentric positions. So they called this good occlusion. And they found that there were other types of occlusion, which we'll show you in a minute, that were quite different from this. So what the patient does, when the patient's anterior teeth prevent contact of the posterior teeth, the patient opens. Then the patient moves to the side with the food. The canines just barely miss each other. And then contact occurs at the last millimeter, and this contact is of short duration and slow and low magnitude. So the periodontal ligaments that surround the roots of the canines tell the patient unconsciously where the jaw is in three-dimensional space. These canines, they know where they are. So you can see here, this is a diagrammatic representation of this type of chewing. And again, Gibbs and Lundin, they called this good occlusion. So if we think about it, let's look from the sagittal view. Now again, this is the classic Posselt's diagram. But when the patient is chewing, the patient opens, comes forward, but again, the teeth don't contact until the very end of that chewing stroke. So if, again, if the anterior teeth prevent contact of the posterior teeth in eccentric positions, this is how the patients chewed. And they did this gnathic replicator tracing on over 200 patients. So this is just a diagrammatic representation of this sagittal view. Again, they call this good occlusion. So there is an approach to designing the occlusion whereby we will eliminate contact of all posterior teeth in eccentric positions. So now, with anterior guidance, okay, the anterior teeth guiding the jaw through three-dimensional space, these anterior teeth will protect the posterior teeth from unfavorable lateral forces. Okay, these anterior teeth will encourage a vertical chewing stroke, as you can see in this diagram here, to protect the posterior teeth from unfavorable forces. But now, once those anterior teeth come into occlusion, these posterior teeth, they act as closure stoppers. They prevent the mandibular anterior teeth from pushing out the maxillary anterior teeth. So the anterior teeth protect the posterior teeth in eccentric movements. The posterior teeth protect the anterior teeth in firm closure. So this is sometimes called mutually protected occlusion. It's also called anterior guided occlusion, canine guided occlusion, or even canine disclusion. They're all the same idea. All right, so this is what Gibbs and Lundeen found. When the anterior teeth do not have sufficient overlap to prevent contact of the posterior teeth in eccentric positions. So you can see the chewing stroke is much different. Remember, with the MIP with a good occlusion, remember that was a sharp point. Okay, this is a blunted point. The chewing stroke is not regular. There's banging and sliding during the function. Now, if we look at the arrangement of these teeth, I don't think an orthodontist would call this a malocclusion, but that's what Gibbs and Lundeen called it. So if I'm going to reconstruct a patient, the type of occlusion that I want to copy is what Gibbs and Lundeen called good occlusion. So, mutually protected occlusion, also called canine disclusion. Now, this is how I test it. I ask the patient, take your jaw and slide it to one side. But we know that's not how the patient's going to chew, right? The patient's going to actually open straight, go to the side with the food, and then come up. But this is how we check it. This is how we check it on the articulator. This is how we check it in the mouth. So if the posterior teeth miss, and you can see here, these posterior teeth, they miss by much less than these posterior teeth. But if the posterior teeth miss, we have mutually protected occlusion. And do I really care how much these posterior teeth miss by? And the answer is I don't. It doesn't make any difference. The teeth are separated. That's all that matters. All right, so if we look at the temporomandibular joint, and we can see here, this is the convexity of the condyle, and it's intimately adapted to the thinnest part of the disc. This is the convexity of the articular eminence, and it's also adapted to the superior thinnest part of the disc. And everything is packed together. This is sometimes called a close packed position. And this is the position when the condyle is in centric relation. And we're going to talk about centric relation. Now, it looks like from this sagittal view that this disc is almost like a donut with a little thin part here instead of a hole. But in reality, it's a saddle. So this disc is attached to the condyle by the medial and lateral collateral ligaments. And during function, this disc will swivel back and forth, and we're going to show you that. So the patient, we ask the patient, open as wide as you can. So this is that closed packed position. As the patient opens, the inferior head of the lateral pterygoid muscle contracts and it pulls the condyle down. The superior head of the lateral pterygoid muscle relaxes. Now this retrodiscal tissue, the superior lamina of these retrodiscal tissue is elastic fibers. So they place some tension on the posterior part of the disc. And the disc has an attachment to the neck of the condyle. And these are fibrous connective tissue attachment. And this helps keep the disc from being displaced forward. So if we look here from this side, the patient opens, this inferior head will contract, superior head will relax. As the condyle moves down, the position of the disc against the condyle changes. Initially, the posterior band of the disc is at 12 o'clock, but with firm opening, the posterior band is now at 3 o'clock. So what happens is this movement of the disc keeps the condyle against the thinnest part of the disc. When the patient wants to close, the elevator muscles will contract. Okay, this inferior head of the lateral pterygoid muscle, this inferior head will relax. The superior head will contract, and then the disc comes back up and is back in the position that it was in. So let's talk about centric relation. Centric relation is a repeatable position. And centric relation comes from complete dentures. At the early part of the 20th century, there were many edentulous patients in the United States. And part of it was because the focal infection theory. And that theory was that if there's an infection any place in the body, it can cause a systemic disease. So inexplicable diseases, such as rheumatoid arthritis, many believe that these were caused by a focal infection. So in 1918, Hunter published an article in Dental Cosmos that was very critical of American dentists because we saved teeth. He felt that these teeth should be extracted to help cure systemic diseases. So as a result, many patients in the first part of the 20th century were edentulous because their physicians thought they'd be better off without their teeth. And these dentists were trying to make complete dentures, and there were no textbooks in those days, so they had to come up with some part of the starting point for occlusion. And what they found was that there was a repeatable position with an edentulous patient that could be returned to over and over and over again. Now, they thought the condyle was centered in the fossa, so they called it centric relation. Now, centric relation is also a hinge position. What they found was that the mandible opened and closed on a hinge when the condyle was in centric relation. So if we think about it, the articulator opens and closes on an axle. An axle is a mechanical center of rotation. The mandible in the head opens and closes on an axis, which is an imaginary center of rotation. So if I could transfer that axis in the patient's head to the articulator would open and close the same way that the patient opens and closes. And then finally, centric relation is a braced position. Remember, we showed you that closed, packed position where everything is intimately adapted. So centric relation is important to us if I don't have teeth, or if I have a dysfunctional MIP, a dysfunctional maximal intercuspal position. Or if I'm going to destroy the MIP because I'm going to prepare all the teeth for crowns. So if I'm going to make 1 or 2 crowns, I don't care about centric relation. It's not important to me. But if I'm going to do a full mouth rehabilitation, centric relation is very important. Now, if we look at the history of centric relation, the first article I'm aware of that used the term centric relation was 1929, and that was Hanau, but he did not invent the term. That term was still in widespread use. Now, if we look at this tracing here, this is called a Gothic arch tracing, and it's 2-dimensional. And it looks like, this is centric relation, this is MIP. It looks like with this 2-dimensional drawing that the condyle is as far back as it can go. So for many years, most definitions of centric relation talked about the condyle being in the most retruded position. And there was a term called the rum position. That is, the condyle was rearmost, uppermost, and midmost. Well, we now know the condyle can't be rearmost and uppermost at the same time. So this is the newest definition of centric relation. It's a maxillomandibular relationship independent of tooth contact, in which the condyles articulate in the anterior superior position, not the most retruded position, against the posterior slopes of the articular eminences. In this position, the mandible is restricted to a purely rotary movement. Okay, so it opens and closes on that axis that we talked about. From this unstrained physiologic maxillomandibular relationship, the patient can make vertical, lateral, or protrusive movements. It is a clinically useful, repeatable reference position. This is the definition from the 9th edition of the glossary. And incidentally, I wrote this definition. Now, the 8th edition had 7 definitions to centric relation. Every definition that had ever been used was included. So that was very confusing to everybody. So one of my goals was to come up with one definition that's all inclusive. And hopefully this definition will withstand the test of time. Now, the condyle can be forced behind centric relation. We know that. There are some studies, most of them in the orthodontic literature, that shows that the mandible can be forced behind centric relation. And when the mandible is behind centric relation, the patient is more likely to be symptomatic. Now, what orthodontists frequently will do is they'll remove the first premolars and bring everything back. And in the process, it's possible for the mandible to be forced behind centric relation. So again, centric relation is not the most posterior relation of the mandible to the maxilla. Now for articulators, this is a fully adjustable articulator. It's the Dinar D5A. Now again, if we look at the history of complete mouth rehabilitation, in the 30s, there were techniques using the lost wax technique where complete mouth rehabilitation was possible with fixed prosthodontics. Now, because balanced occlusion with complete dentures has been so successful, they tried to copy that approach to occlusion. So they tried to balance the occlusion with fixed prosthodontics. Well, it didn't take very long before they realized that this really was not working. Now, if I want to balance the occlusion with fixed prosthodontics, how else could I do it without a very sophisticated instrument? And that's why this instrument was developed. And if we look at the research on occlusion that was done in the first half of the 20th century, much of it was on articulators. Well, once we realized that balancing the occlusion for fixed prosthodontics was not the best idea, the fully adjustable articulator kind of went out of popularity. Now, this is a pantograph. This is an old style pantograph, so it shows how long it's been since I've used a fully adjustable articulator. Do I really need to use this behemoth device to program an articulator if my objective is mutually protected occlusion? I just want those posterior teeth to miss. So if we look at the pantograph, now this is the Stewart pantograph. The Stewart was the first fully adjustable articulator. The tables were stable, fixed, and then during motion, the styli, or the needles, would move. So, all right, so this is the sagittal table, and you can see that when the patient moves the jaw to this side, the condyle is going down. Now, if we look at this table, the horizontal table, this is straight protrusion, okay, and this is non-working movement. The condyle is moving inward or medially. So the condyle, when the patient moves to the right, the opposite condyle moves downward, forward, and inward. And this angle between these two movements, straight protrusion and non-working, that's called the Bennett angle. Well, Guichet, and that's the inventor of the D5A, which we just showed you, he developed a pantograph where the table itself would move. So the styli that made the tracing, there were elastics on here to hold it tight against the table. The table would move, the styli would remain stable. And what Guichet noticed, he said, it appears that this Bennett angle starts out with an immediate side shift. And then there is a progressive side shift. So now suddenly, to do full mouth rehabilitation with fixed, we had to know how much the immediate side shift was. So now suddenly the pantograph and the fully adjustable articulator went back into popularity. Now this artwork is not mine. This is from Dawson's textbook. Dawson is very famous, just recently deceased, and he has multiple textbooks on occlusion. But Dawson felt that this immediate side shift was an artifact of the tracing itself because the tracing table moved, not the styli. Okay, this study by Craddock, he did pantographic tracings on an articulator. So he knew what the settings were. And what he found, when the immediate side shift, we now call it immediate mandibular lateral translation, rolls right off the tongue. But when the immediate mandibular lateral translation on the articulator was set at 0, depending on where these tables were in relationship to the axle on the articulator, we could get what looked like an immediate side shift. Now, Taylor and his group, they did a systematic review, which they published less than 5 years ago, and their conclusion was that the immediate side shift most likely does not exist. It's an artifact to the tracing itself. And their second conclusion was, even if it does exist, there is no clinical relevance. So the idea that I have to do a pantographic tracing and set an immediate side shift on my articulator really has no scientific basis at all. So we use the DNR Mark II, which is a semi-adjustable version of the D5A, and there is an adjustment for the immediate side shift or the immediate mandibular lateral translation, and we always set it at 0. Because what appears to be that side shift is just an artifact to the two-dimensional tracing device. Now, there is an electronic pantograph, and I've never used it. And Chang did a study 15 years ago on the accuracy of this pantograph. And he had articulators, so he knew what the settings were. And he did the electronic pantograph on an articulator. And what he found was it's most accurate 10 millimeters from centric relation. And it's least accurate as the condylar ball leaves centric relation. Well, we want it to be most accurate as it leaves centric relation. We don't care where it is 10 millimeters away from centric relation. So again, I'm not saying that there's anything wrong with using a pantograph. I just think it is unnecessary. So immediate mandibular lateral translation, which Guichet called immediate side shift. This is the newer definition, and I wrote this myself. Transitory portion of the lateral movement in which the non-working side condyle appears to move essentially in a straight line and medially on a two-dimensional tracing as it leaves centric relation position. So the words in yellow are the words that I added to the original definition. But even more importantly, remember this picture from Gibbs and Lundeen. MIP is a sharp point. How could MIP be a sharp point if there was an immediate mandibular lateral translation? It would be blunted. Also, how does the patient chew? The patient opens straight, then moves to the working side. So how does that immediate mandibular lateral translation mean anything? It doesn't mean anything. This is good occlusion. This is what we're going to copy with our complete mouth rehabilitation. So I'm going to use a semi-adjustable articulator. And I'm going to set it for negative error. So let's review what we mean by positive error and negative error. So I drew this myself, and these numbers are made up, but just imagine that the angle here of the articular eminence is 30 degrees in relationship to the floor, to the horizontal angle. So when the patient slides forward, the condyle is going to drop at an angle of 30 degrees, and that will separate the posterior teeth. Now, just imagine if I set my articulator with the condylar guidance at 20. And then I design the occlusion so that when the patient moves straight forward, the teeth touch. Well, when I put these crowns in the mouth, what touched on the articulator is going to miss in the mouth because the condyle is going to drop at a steeper angle. So this dotted line represents the patient, and the solid line represents the articulator. So if I design my occlusion so that the posterior teeth miss in the mouth, in straight protrusion, the posterior teeth will miss by more in the mouth. Now, if I do the reverse, if I make the condylar guidance on the articulator steeper than what the patient has, then we will create an interference, which we don't want to do. So if what missed on the articulator misses by more in the mouth, that's called negative error. If what contacts on the articulator is an interference in the mouth, that's called positive error. Now, if we look at this article by Lundeen and Worth, it's the same Lundeen. They did tracings on a number of patients, and what they found was the natural condylar inclination in the mouth ranged from 25 to 65 with a mean of 40. So if I set my articulator at 20, I'm below the mean. So if I design the posterior occlusion in eccentric positions to miss on the articulator, they'll miss by more in the mouth. And do I care how much they miss by? No, I don't care how much they miss by. So if I set the protrusive angle on my articulator at 20, and I know the patient is between 25 and 65, in straight protrusion and in non-working, posterior teeth will miss. Now, what about on the working side? So as the patient moves to this side, we know what happens here, right? This is the Bennett angle. So this is straight protrusion. This is non-working movement. The angle formed here influences how much lateral movement there is on the opposite side. The wider the Bennett angle, the more lateral movement on the working side. Now, this used to be called the Bennett shift. So again, from Lundin and Worth, we know that the Bennett angle in the natural dentition is between 6 and 8 degrees with a mean of 7. Very small range. So if I set the Bennett angle at double, set it at 15, the articulator on the working side, the teeth will move further laterally than in the head. So when I put these crowns in the patient's mouth and the patient moves laterally, okay, if I set the condylar guidance at 20, on the non-working side, there'll be disclusion that's more in the mouth than on the articulator. And then on the working side, there'll be disclusion in eccentric movement in the mouth that's more than on the articulator. So I'll create negative error. Okay, because I made this 15, these teeth could move further out on the articulator than the patient can. So if they missed, they'll miss by more because the patient can't get there. All right, so this is the Mark II. We're going to set the protrusive angle or the horizontal angle at 20. And we're going to set the Bennett angle at 15. And we're going to set the immediate mandibular lateral translation at 0. Okay, so the arrangement of the anterior teeth determines my anterior guidance. It determines my envelope of function. Now, the way we test this is we have the patient close into MIP. This is a lingual view, and we say, okay, slide your jaw forward. Okay, but that's not how the patient chews, right? When the patient chews, they open straight, come out, and come back up. So what I want is, when the patient goes into any eccentric movement, I want the posterior teeth to miss. I don't care how much they miss by. Now, anterior guidance also is important for aesthetics and phonetics. And it's the periodontal ligaments that really allow us to chew with such precision. There are mechanoreceptors within the periodontal ligament that can detect micro movement in any direction, so that when we close into our maximal intercuspal position, we don't think about it. We just automatically close. All right, so here's that case we're going to show. We're going to go step by step. And this is actually Dr. Dmitry Svirsky's board patient. Okay, there's one patient for the board that's a major reconstruction with fixed prosthodontics. And this was his case. And I like to show this case because there were a lot of decisions we had to make. Obviously, the anterior guidance is dysfunctional, so we had to change the anterior guidance. All right, so you can see some of these teeth are going to come out. And that's her anterior guidance. Obviously, it's dysfunctional. So how do we decide where the incisal edges of the two maxillary central incisors should be? We use aesthetics and phonetics, and we're guessing. Sometimes we guess right, sometimes we don't. Luckily, this time we guessed right. So remember, using principles of complete denture. And remember, complete dentures is, if I make maxillary mandibular complete dentures, that's a complete mouth rehabilitation. It's just removable. So the incisal edge should brush the lower lip at or near the wet-dry line. When the patient says S, the incisal edges of the maxillary and mandibular anterior teeth should come very close together, 1 to 1.5 millimeters apart. So you can see here, this is the patient's MIP. Okay, these fixed partial dentures all have to be changed. They're defective. So we do a diagnostic mounting. We're going to take a Facebook record. I want to transfer the patient's hinge axis in the head to the axle on the articulator. So the articulator will open and close similar to the way the patient opens and closes. And then we're going to make a centric relation record. Now, to make a centric relation record, it's independent of tooth contact. So when I'm doing my diagnostic mounting, it has to be made at an increased vertical dimension of occlusion. There's no other way to do it. Also, remember, the periodontal ligament knows how my teeth fit together. And for most patients, the way my teeth fit together, the condyl's not in centric relation. So we have to deprogram the patient's muscles by allowing the patient to forget how the teeth fit together. So Lucia described an anterior device, he called it a jig, that would separate the teeth. And with the teeth separated, the mandible eventually will seek centric relation. The mandible eventually will go to centric relation, but it's time dependent. So what I normally do is I will make this jig, I'll mark it where the embrasure is between the two central incisors. You're going to see from a different view, we couldn't do that with this patient. And then watch. Every 10 minutes, I'm going to watch. Usually the mandible will go slightly backward and slightly to the side. When the mandible stops doing that, we will then make our centric relation record. Now we use a wafer of extra hard base plate wax. We happen to use Beauty Pink wax, but Dentsply also makes a wax. And then we reline it with Tempbond, which is a zinc oxide eugenol paste. And study by Muller has shown that this is as accurate as any centric relation record technique. Now he recommends that it be mounted within an hour because there could be some dimensional change in the wax itself. But the advantage of a wafer, it goes across the palate. We can check it, we can verify it. So we're going to mount the maxillary cast with Facebook. Mount the mandibular cast with a centric relation record. Now this record should not touch the stone. So this wax here that touches the stone, this was liquid wax that was there just to help stabilize the record. Okay, now this is the mounted diagnostic casts with the condyles in centric relation. All right, so obviously we have to change the anterior guidance. So again, at the diagnostic visit, we marked the wet-dry line. And we had the patient speak. And then from that, we guessed on where the incisal edge of 8 and 9, or the two central incisors. The two central incisors should be. Then we had the patient say S sounds. And then we guessed on where the incisal edge of the mandibular anterior teeth should be. Right, so this is Dr. Svirsky's diagnostic waxing. He did this himself. The mandibular 4 incisors are going to be extracted, and then the two central incisors and the left lateral incisor will also be extracted. Right, so this is our proposed anterior arrangement of the teeth. So we develop canine disclusion. Okay, we have the articulator set for negative error. So these posterior teeth miss on the articulator, and when we put them in the mouth, they'll miss by more in the mouth. This is straight protrusion. All right, so Dr. Svirsky invested these and processed these as a shell, which will be relined at delivery. All right, so this is delivery here. You can see some teeth were extracted. This is after some healing, and you can see that there's been some shrinkage of the soft tissue, so the teeth will have to be re-prepared. And this is my first set of provisional restorations. Generally, we'll do 2 sets. And we were lucky here. The patient looked nice. She could say F correctly, and she could say S correctly. All right, so these are the preparations. And this is the second set of provisional restorations. And the technician is going to use this as a blueprint on how to make the definitive restorations. And we're going to show you how we do that. All right, so this is the patient. So we're going to make final impressions. Now, frequently we don't get every tooth, especially in the mandible, because no matter where that tongue is, it's in the way. And you're going to see here, we ended up with 2 casts in the mandible, but eventually that becomes 1 cast. So we're going to make our impressions. Okay, we're going to do another face bow record. And we're going to do another centric relation record. We're going to set the controls on the articulator for negative error. Okay, so protrusive angle or horizontal angle is 20, bended angle is 15. Therefore, whatever missed in eccentric positions on the articulator will miss by more in the mouth. All right, so these are the dies mounted. And again, you can see there's 2 mandibular casts. This cast to the right is different from this cast here. Now we're going to do cross-mounting. What cross-mounting does is I can remove the cast of the provisional restorations and replace it with the dies, and everything is interchangeable. So we need to make one more interocclusal record. And the record is on tooth preparations in one arch and the provisional restorations in the opposing arch at the established vertical dimension of occlusion. So normally what I will do is the arch that I chose for the tooth preparations is the arch with the most preparations. It helps stabilize the record. Now, we want at the exact vertical dimension of occlusion. And there's 2 ways to do this. One is to make another Lucia jig at the exact vertical, measuring 2 fixed landmarks, and I will usually measure from cervical line of the maxillary canine to cervical line of the mandibular premolar, first premolar. And then make the record with the jig in the mouth, so the jig stops the patient at the exact vertical I want. Okay, another option is to just measure it as the record is being made. So because this patient didn't have mandibular teeth here, Dr. Svirsky did not use a jig. So from the beginning, I know exactly what that distance is, and I write it down in the chart. So if it's 22, I always can go back to the chart and know exactly what that distance should be. Okay, so we have that record now. We have that maxillary provisional arch with a record against the mandibular preparations. So the casts with the preparations, they're already mounted. So I take the record, place the record on top of the mandibular preparations, take the cast off with the maxillary preparations, and mount the maxillary cast of the diagnostic, of the provisional restorations, which came from the diagnostic waxing. Then I will remove the mandibular cast with the tooth preparations, and I will hand articulate the mandibular cast of the provisional restorations. So now everything's interchangeable. Now we're going to use these casts of the provisional restorations as a blueprint to guide the technician. So we want the technician to place the midline exactly where we have it, the incisal edges of the maxillary and mandibular anterior teeth exactly where we have them. We also want the lingual contours of those maxillary anterior teeth to mimic what's on the provisional restorations. And the way we do that is we make a custom anterior guide table. So we take some softened acrylic resin, place it on this disposable guide table. We take this guide pin, or this incisal pin, has a rounded tip. We sink it into the softened acrylic resin, and we move the articulator in eccentric positions. And we keep doing that until it polymerizes and hardens. Now, normally I put cellophane in between these teeth to avoid chipping the teeth. Now, after this is done, usually there's a little lip here that catches this pin as we open and close the articulator. So I'll take acrylic resin burr and I'll open that up just a little bit. But now the technician can use this guide table to contour the lingual surfaces of the maxillary anterior teeth. All right, so these are all the castings. Now, at this point, we're going to try them in. We're going to fit them the way we would fit castings in any patient's mouth. But we're going to make a new centric relation record. And we're going to make this record with a jig. And I made this jig in the lab at the exact vertical dimension of occlusion that I want. And now it's easy to take a centric relation record because there is no MIP. We've taken the provisional restorations off, so the patient immediately forgets what the MIP was. Now, if we look at this article by Virgos and Tripodakis, what they found was there is an error with any interocclusal record, but the primary error occurs when we transfer this interocclusal record from the tooth preparations in the mouth to the dies on the casts. That's the primary source of error. So if I make this record on top of the castings, I've eliminated that error. In the mouth, the record sits on the castings. On the cast, when I'm mounting the mandibular cast, it's also sitting on the castings. Now also, we have all these pontics. We have a much larger surface area to help stabilize the record. So in the end, this record is the most accurate record that we're going to get because it's made under the most favorable conditions. And again, because I made this jig on the articulator at the exact vertical dimension of occlusion that I want, we've held the vertical dimension of occlusion exactly. Now remember, we had 2 casts in the mandible. We don't want to have 2 casts in the mandible. So we're going to do a pickup impression of the castings. So I'll put Fit Checker, which is a silicone disclosing material, inside the restorations to help stabilize them. And then we'll make a pickup impression. So this is the pickup impression. Now we've got to do the record first. Remember, the record was made on the castings, and it's going to sit back on those castings when we do the remount. All right, so this is my pickup cast. So this is soft tissue replica. It's a silicone. We put the ridge in regular stone because technicians prefer, when adapting the pontic, to deal with stone rather than dealing with silicone. All right, so these are the castings on my pickup cast. Now notice here too, we made these proximal struts come way up like this. And the reason we do that is we're not sure if we have to solder this. And if we have to solder, we need something to solder to. Now, once we're sure we don't have to solder, the technician's going to bring these back down, and you'll see that. And we did the same thing in the mandible too. We're not sure, we might have to solder here, and we need some metal to solder to. And again, these are going to be brought back down. So we make what we call a facebow preservation. So we have this remount platform, we put some plaster, and we make an imprint of the castings on the cast with the removable dies. Then we take the pickup cast and we just drop it on that index, that facebow preservation, and we mount the maxillary cast. All right, so now we've got the jig. We can put that on. We've got the interocclusal record, centric relation record, with the reline with temp bond. Now you can notice some areas there's show through of the wax, and some areas there isn't. So what this temp bond does, when this wax is warm, as it cools, it shrinks. But it doesn't shrink uniformly. So this temp bond compensates for this shrinkage that's occurring, and it also helps make the record more stable. All right, so these are the casts mounted. And this is the space available to the technician for the ceramics. Now, without more information, nobody could do a good job doing this ceramics. We've got to give the technician a lot more information. So one thing we have is we've got the provisional restorations. We've got this custom anterior guide table. Now we make an index of the incisal edges of the provisional restorations. That way the technician knows what the incisal line should be. The incisal line should match the interpupillary line, just like with complete dentures. The technician knows where the midline is. The technician knows how far facially the incisal edge should go. So these are the final restorations. These are the restorations in the mouth. So you can see we have canine disclusion. Again, we don't care how much the posterior teeth miss, as long as they miss. And then, of course, everybody gets a night guard. Now, we do a lot of night guards because we do a lot of cases like this. So we're very good at making night guards. Now, whether the patient wears it or not is a different story. But every patient with a full mouth rehabilitation like this will be getting a night guard. Okay, so this is before and this is after. Okay, this is before and this is after. And you can see the patient can't even get her lips together in the before picture because of the dysfunctional arrangement of her anterior teeth. And you can see in the after that when she says F, that incisal edge is going to just brush that lower lip right near the wet-dry line. Okay, so using the principles that we use for complete dentures, we determined how to develop an anterior guidance from what was from the beginning a dysfunctional anterior guidance. All right, so what are the conclusions? Okay, we're going to develop mutually protected occlusion. Gibbs and Lundin called that good occlusion because that's the type of occlusal arrangement where the patient functioned best. We're going to use a semi-adjustable articulator. There's no real reason to use anything more sophisticated than a semi-adjustable articulator. I want to develop an anterior guidance so that the posterior teeth disclude in all eccentric positions. We're going to use negative error. Okay, I know from Lundin and Worth that patients' condylar guidance ranges between 25 and 65 degrees. The mean is 40. So if I set the condylar guidance at 20 degrees, I'm below the range, which means what missed on the articulator will miss by more in the mouth. My Bennett angle, again, from Lundin and Worth, I know that the Bennett angle in the natural dentition is very narrow, and there's very little range. Range is between 6 and 8 degrees. So if I double it at 15 degrees, we'll create negative error on the working side. We're going to set the immediate mandibular lateral translation, also called the immediate side shift. We're going to set it at 0. There's no real scientific evidence that it exists. It could very easily just be an artifact of the tracing device. And a systematic review by Taylor et al. Showed that if it does exist, there is no clinical relevance to the immediate mandibular lateral translation. Okay, we're going to use a Lucia jig when we make our centric relation record. Okay, we use it for diagnosis. So the jig separates the teeth. Remember, centric relation is independent of tooth contact. We have to eliminate tooth contacts. But also, as Gibbs and Lundin showed us, when patients chew, they go right into MIP. The brain knows how the teeth fit together best, and we have to make the patient forget how the teeth fit together best, because the patient doesn't want to close in centric relation. They know the teeth don't fit right in centric relation. So if we keep the teeth separated long enough, the condyle will seek and find centric relation position. I'm going to use a wax wafer, extra hard base plate wax. And then I'm going to reline it with a ZOE paste, which is just Tempond. Okay, this has been shown to be as accurate as any method. It's easy to do, it's easy to check. I can have the patient keep closing into that position, make sure that the patient is right into centric relation. We're going to do cross mounting. The technician needs an enormous amount of information to be able to do the ceramics and do the castings. So cross-mounting of the provisional restorations serves as a blueprint for the technician. Okay, we're going to make a custom anterior guide table, and we do that from the cast of the provisional restorations. We've already tested these provisional restorations out. We know aesthetically it's good. We knew that the incisal line matches the interpupillary line. We know the midline matches the middle of the face. We know the F is good. We know the S is good. So what we want is we want the technician to copy what we did with the provisional restorations. And then finally, when we try in the castings, or we try in the frameworks, we're going to make a new centric relation record on top of these frameworks, because we know this is the most accurate record that we've made. And we've made more than one, but this is the most accurate record that we've made because this record was made under the best conditions. Thank you very much.
I thank Professor Stephen Morgano for such excellent presentation. And now we have a chance to answer some questions. And just before we go to the question, I just posted a link for the evaluation form in which everyone can access to get their credit hours, and also you can use the QR code which is on the screen to access the evaluation form and to get the credit hours. So I just wanted to start with some questions. The first question is, what would be your selected occlusion scheme for single upper complete denture when opposed with number 1, lower partial denture with distal extension and with lower full natural teeth?
Okay, so I'm just going to repeat the question, make sure I have it right. I have a maxillary single complete denture, occluding with a mandibular removable partial denture with extension base.
Yes.
Okay, so when designing the occlusion, we always want to favor the weakest prosthesis. The weakest prosthesis would be the maxillary complete denture. So because the maxillary complete denture is the weakest prosthesis, we're going to develop classical balanced occlusion or balanced lingualized occlusion. Now, balanced occlusion is not the best occlusion for a removable partial denture. So if I didn't have a complete denture, if I had a natural anterior guidance in the maxilla and then another RPD, we would use canine disclusion. Now in the mandible, if I have a natural complement of teeth, we would attempt to develop lingualized balanced occlusion. If we cannot, then I would slightly flatten the mandibular posterior teeth and develop cusp tip to cusp tip occlusion. This has been described by Yerkstis. And incidentally, Yerkstis was chairman of complete dentures when I went to Tufts Dental School. So I learned this technique from him. I hope that answers the question.
Yes. Thank you. The second question is, what is the difference between canine guidance and anterior cuspid guidance, which sometimes are referred to in the articles?
Yeah, they're the same. Canine guidance and anterior cuspid guidance, they're the same. The cuspid is the canine. And like I said, even if they say anterior guidance, that's the same as canine guidance. If they say mutually protected occlusion, that's the same as canine guidance. Now, technically, if only the canine contacts in a lateral movement, then that's technically canine guidance. If the lateral movement includes contact of the incisors, then that's anterior guidance. But they all function the same. So basically, it's all the same.
Excellent. Thank you. The third question is, can we use canine guidance as the occlusion for complete denture? Is selecting balancing occlusion for complete denture evidence-based or only a common practice?
Yeah, that's an excellent question, actually. All right, there is some research that has shown that patients can chew better with either classically balanced occlusion or balanced lingualized occlusion. There's one by Kamis, there's one by Sutton and McCord. Also, there is, Sutton and McCord showed that patients are more comfortable with balanced occlusion. Now, there are some articles where they checked patient satisfaction, and they made dentures with canine guidance. And some patients actually were happy with it. And partly, I think it's because of the aesthetics. You can get better aesthetics maybe with a steep overlap of the anterior teeth. But my experience has been if the anterior teeth contact in eccentric positions and the posterior teeth separate, that eventually the patients complain that the maxillary denture is dropping in the back. Now, no matter what, maxillary and mandibular anterior teeth, when the patient is in MIP, they should not touch. There has to be a slight space. And if we look, there's a study by Brudvik that showed that when people chew with complete dentures, they don't come any further forward than 1.5 millimeters. And then there's a study by Loser and Jordan. And what he found was if the overlap, the horizontal overlap is 2 millimeters, it's easier to balance the occlusion. Now, some textbooks give you a number. This is how much the overlap should be. But that doesn't work for everybody because it's aesthetics and phonetics that determine the anterior arrangement. Class 2 patients, they come way forward when they say S, in which case there has to be more of the overjet with a class 2 patient than with a class 1 patient. Class 3 patients, they tend to come up and down when they say S. They don't go forward. There's no reason to go forward because the lower teeth will be in front of the upper teeth. So it depends a lot on aesthetics and phonetics, how much of the overlap we have. And again, there are some studies with patients with complete dentures, with anterior guidance, like them.
Excellent. The other question is how these concepts of occlusion are different with full mouth fixed implant rehabilitation.
Yeah, I knew this question was going to come up. I knew it. Okay, the thing with complete mouth rehabilitation with natural dentition, and I specifically picked one that didn't have implants, there's proprioception in the periodontal ligament. So it's very easy to manage because the patient knows where the jaw is in three-dimensional space. It's unconscious, but they know. So just like when I walk upstairs, I put my foot on the first stair and I know where all the stairs are now. So I can walk upstairs, not think about it. I can be eating an apple, talking to somebody, but just try walking up an escalator that's broken. Each stair at the beginning gets taller and taller and taller. And then at the end, each stair gets shorter and shorter and shorter. So I have to pay attention and watch my feet. So with implants, we don't have that same exquisite sensation. So if it's a complete mouth rehabilitation with implants, I will usually develop shallow anterior guidance. Now, sometimes with aesthetics and phonetics, I can't. And that's when we are likely to have problems mechanically. So initially when we did these cases, I'm old enough to remember we didn't have implants. When we did these cases, we didn't do them any differently from a patient with natural teeth. But what we found was if we had too much overlap vertically, patients were chipping the porcelain. And there's other small little things. Patients will tell me, you know, when I go to drink from a glass, I don't know where my teeth are, and I keep bumping my teeth, and then sometimes they can chip the porcelain that way too. So we try to develop anterior guidance that's very shallow.
Excellent. The other question is, do you always set the condylar angle arbitrary for fixed and removable rehabilitation?
Okay, that's an excellent question too. I set the condylar guidance arbitrarily for fixed. For complete dentures, I'm going to take a protrusive record and I'm going to set the horizontal angle or the protrusive angle using the protrusive record. And then I'm going to set the bended angle at 15. And the question is, well, why would you set it at 15? For some reason, and I don't know why, when they do studies on bended angles, the bended angle for an edentulous patient is usually wider than the bended angle for a patient with natural dentition. So Langer and Mitchman, they found that the average bended angle for an edentulous patient was 17. And then if you look at Giese, he found that the average bended angle was 15. And if you look at the formula, the Hanau formula, that's right on the Hanau Articulator, he says you should use his formula to set the bended angle. The bended angle was H, which is the horizontal record, or the horizontal reading, divided by 8 plus 12. And the way he did that was he knew that it was almost always going to be 15. So he created a formula where it would be almost always 15. If it was 25, if the condylar guidance was 25, it would be 15.
Excellent. The other question is, in which cases you recommend to use a group function over canine guidance occlusion?
Yeah, that's another excellent question. Okay, if we just can't get canine guidance, patient is a severe class 2 patient, and the canines are just too far away, then we would use group function. And the way we do group function is we use the functionally generated path. And that's described really quite well in Dawson's older textbook, how to do the functionally generated path. And originally, when we were doing big reconstructions with fixed on implants, rather than develop canine guidance, we used group function. And we did that using the functionally generated path. And it really does work. Once a technician has done it once, it really does work.
Okay. The other question is, do you believe in using a Facebook? It is very arbitrary, and there are studies showing different Facebook records of the same case, or not to result in the same amounting. So do you believe in the Facebook?
Okay, Teteruck and Lundin evaluated an ear Facebook, and it was the Whitmix Facebook. And what they found was that 76% of the time, the axis that was transferred to the articulator was within 6 millimeters. Now, Weinberg did a study, and this was geometric calculations, not on an articulator. He found that if the hinge axis was off by 5 millimeters, and I made an interocclusal record that was 3 millimeters thick at the last molar. So 3 millimeters thick at the last molar means 9 millimeters thick in the anterior. And then I mounted the cast and closed the articulator down. The error would be 0.196 millimeters, or 0.2 of a millimeter. Now, no one's going to make a record that's 9 millimeters thick. And for each millimeter we close, the error is slightly more than 0.01 millimeters. So I do use a Facebook. It's arbitrary. It's arbitrary, but I do use a Facebook.
Okay. So the other question is, how much of these concepts are changed now that dentistry is moving toward fully digitalized techniques?
Yeah, that's an excellent question too. The principles are still the same. Tooth preparations are still the same. Centric relation is still the same. Okay. Condylar guidance is still the same. Now, one thing that is different is we're not doing so much metal ceramics anymore. So the step where I take that interocclusal record on top of the metal castings may not be so valuable anymore because we may not have a metal casting.
Okay, so the other question is, what do you think of virtual articulation?
Yeah, I'm not so sure that it's such a problem if I want to disclude. If I want to disclude the posterior teeth, I don't care how much they disclude by. So I don't think it's such a problem if I want to disclude. If I want to balance the occlusion, some systems allow me to adjust the condylar guidance and some don't. Now, the system we're using for complete dentures at Rutgers, the whole thing is analog up until jaw records. So we make jaw records on regular occlusion rims. Then what we do is we scan the cast, and then we scan the occlusion rims, and then everything else is done on a computer. So we can take a protrusive record because we have record bases. We can take a protrusive record, and then whatever number it comes out, we can set that on the computer so that we can balance the occlusion.
Okay, there is a question which is that the registration bite that they use as silicone instead of wax. Is there any advantage of any type of material, if it's silicone or wax?
Okay, we can use silicone, we can use polyether, we can use wax. Now, again, the advantage of wax, I can recheck it. I can't recheck a silicone or a polyether record. I can't recheck it. So if I have a wafer that I can hold in the mouth, I can ask the patient to close, and they keep closing exactly the same way right into the indentations, then I'm reasonably certain the record is accurate. What we've seen is that no record is 100%. There's some error in every record. And of course, there's error in the mounting stone too, so nothing is 100%. But extra hard base plate wax relined with temp bond is as accurate as any other material. The only thing that they would recommend is don't wait more than an hour to mount the cast. And again, if you noticed when Dr. Swirsky mounted his casts, he didn't mount them real neat. He just got them on there. And then later on, he neatened up the mounting, but he just wanted to get everything on there right away. So anyway, I don't think that there's anything that's wrong with using silicone. You know, it's quick, that's for sure. And if it's just a 300 fixed partial denture, for example, just have the patient close into MIP and squirt some of that material in there, and that's going to be perfectly fine. You know, I prefer something that's very hard rather than something that's flexible, because if it's flexible and it's wrong, I can, you know, flex it on the cast and it looks like it's right. But if it's a full mouth rehabilitation, I prefer wax with temp bond.
Excellent. The other question is there any disadvantage of not using the anterior jig in the presented case during the cross mounting?
Okay, when we did the cross mount, first of all, I use a jig if you want to know, but because there were no mandibular incisors, it's a little more difficult to use a jig. Normally the jig contacts the mandibular incisors. So I think the thing is, if I'm not using a jig, I have to be sure the patient didn't close too much or not enough. So I have to really measure. And I do that right from the beginning. Before I even start the tooth preparations, I'm going to measure the distance between the cervical line, the maxillary canine, and the cervical line of the mandibular premolar, or the canine, depending on which one is easier to measure. And I'm going to write it down. And sometimes we change the vertical dimension of occlusion. And at least I know where my starting point was. And then when I do that last centric relation record, I'm going to use a jig. But the jig's made in the lab ahead of time at the exact vertical dimension of occlusion. So I know that I'm going to preserve the vertical dimension of occlusion. And centric relation can be made without a jig. I mean, we use the jig because it's easy to teach and it's easy to do. And it's very reliable. And remember, this is 64. Victor Lucia talked about this in 1964, so it's been around a long time.
Okay, the other question is, what is your view on the reports that most occlusal concepts lack scientific evidence supporting their clinical benefits?
Most things in dentistry lack scientific evidence. Most things. So we have to work with what we have. You know, evidence-based dentistry means using the best available evidence, plus clinical judgment, plus our own experience. So we're looking for an approach that's going to work. Now, Gibbs and Lundeen have shown us anterior disclusion is very favorable. The chewing stroke was very smooth, reproducible. The anterior teeth didn't bang and slide against each other. And there used to be arguments all the time in the 60s. Now, if we look at group function was first described by Clyde Schuyler, and he was a New York dentist. And people began to realize that balancing side contacts or non-working side contacts with fixed was not working. So what he suggested, okay, let's forget the balancing side contacts, just have the working side contacts. He called that unilateral balance, which later became known as group function. So in the northeastern part of the United States, we were doing things with group function when we did major fixed restorations. On the West Coast, they were using canine disclusion. And there were all these arguments, mostly among periodontists actually. Why would you put all of the eccentric load on one tooth? And the answer was, well, we're doing it and it's working. Now, they didn't have the evidence to show why it was working. But Gibbs and Lundeen, they've really kind of ended that argument a long, long time ago because they've proven we're not putting all the load on one tooth. The canines are just barely missing if the canines prevent contact with the posterior teeth. So there's no perfect evidence, that's for certain. And mutually protected occlusion, it's the easiest way to do a rehabilitation. So we're very lucky. You know, in prosthodontics, usually the easiest way is not the best way. But evidence suggests that anterior disclusion or mutually protected occlusion or canine disclusion is the best. And it's also the easiest.
Excellent. Now there is another question. A patient with TMJ clicking, which occlusion is the preferred?
That's an excellent question too. Now, if you look at the research on clicking, clicking is associated with disc displacement, anterior displacement of the disc. And if you look at the research on how many people have a displaced disc, it's about 1/3 of the population has a displaced disc. Now, the displaced disc doesn't always cause clicking. And frequently what happens is, you know, that posterior band of the disc now is in front of the condyle. So as the patient opens, the condyle goes back to that thin part of the disc where it's supposed to be. And during that movement, there's a click. And then usually when they close, there's another click. They call it a reciprocal click. But there is a study that has shown, and the study was McDivitt. There's a study that has shown that patients with a displaced disc, they have a position that acts exactly like centric relation. And if you looked at the old definition of centric relation, the one in the 8th edition, it talks about the condyle being against the thinnest part of the disc. If you look at my definition, I took that out for the simple reason I don't know where the disc is. And secondly, if it has to be against the thinnest part of the disc, that means 1/3 of the patients don't have a centric relation. So McDivitt, using MRIs and everything, showed that there is a position just like centric relation. And what people think happens is the retrodiscal tissue, remember we talked about that, when the disc is displaced forward, the retrodiscal tissue can undergo histologic changes and become what they call a pseudodisc. So it acts like a disc. So patients with clicking, okay, and there's really no treatment for clicking. You know, if the patient says, I have a click, you say, well, you know, it's annoying, but there's really no treatment. But patients with clicking, we use the same approach, exactly the same approach.
Thank you, Professor Morgano, for such excellent presentation. We have many other questions, but unfortunately we are out of time. And I just want to inform all our colleagues who did attend this presentation that please access the link that I will publish again. And this link, it will allow you to go to the evaluation form, and by filling the evaluation, we're going to be able to get the credit hours. Again, I want to thank Professor Stephen Morgano for such excellent presentation and for his time. And hopefully we will gonna have more presentation and a collaboration between our schools. So thank you.
Thank you.